Welcome, everybody. We'll get started in just a minute. I want to give a couple minutes for everyone to drop in. All right, welcome everyone. Thank you so much for joining the Link Center today for this shared learning group focusing on supporting someone in crisis. I'm going to go over a few housekeeping items while we get started today. We do have live captioning and ASL interpreters present today. This session will be recorded, and the recording and the transcript will be shared with attendees. The PowerPoint and documents that we reviewed today will also be shared with everyone via email. We welcome you to revisit the content yourself and share it with your colleagues. Attendees cannot see the names of other attendees, but you can see all of the hosts and panelists, and all attendees are muted. Please feel free to use the chat function in Zoom to communicate with other attendees or the hosts in the webinar. You can use the chat by clicking on chat at the bottom of your screen. Be aware that your name will appear in the chat if you make a comment, but you can change your display name if you want to by clicking on the little 3 dots next to your name and selecting rename. We will have representatives from the Link Center watching the chat and responding throughout the session today. And if you would prefer to submit a question or a comment anonymously, you can do that to the host and panelists by clicking on the Q&A function at the bottom of your screen. Following the webinar today, you will receive an email with the material that we review, the recording and the transcript, as well as an evaluation that we ask you please complete in response to today's shared learning group. So at this time, I'm going to hand the floor over to Mary Sowers, who's going to start today's presentation. Mary, it's all yours.
Thank you so much, Stephanie, and welcome everyone to the Link Center's shared learning group on supporting individuals in crisis. We'll talk a bit today about the Link Center, but we are really aimed at elevating good practices to help bridge mental health systems, to ensure strong clinical support and home and community-based services for individuals with IDD and TBI and other cognitive disabilities. We're really especially thrilled to have all of you today wearing a clinician hat. And we really hope to be able to make this as useful for all of you as possible. Next slide. We're especially grateful for the Administration for Community Living's leadership in this work. And the shared learning group is just one component of the Link Center. We'll go through some of the other activities of the Link Center in a bit. But today we will be hosting, today and tomorrow, we'll be hosting 4 meetings of the shared learning groups. And some of the key elements of the Link Center are really aimed at identifying strong resources for 4 primary groups of folks: direct support professionals, clinical professionals, individuals with lived experiences, and families. You'll note that we've kept the content consistent across the audiences for these groups, but we're changing the discussion to really tailor it to your day-to-day work and to make it applicable in how you think about supporting individuals with cognitive disabilities in the mental health space. This content is really a reflection of a strong collaboration among the Link Center partners, many of whom you'll meet today in the presentation, but it includes individuals with lived experience, individuals who are researchers, and individuals who work on policy issues. And so you'll, again, through this conversation today, get to meet some of our key partners. We will be transcribing and recording today's meeting, and the materials will be sent after the meeting through an email. And we hope that you'll use that to reflect on the time together today, but also perhaps to share with other colleagues who weren't able to make it. And we'll be making these resources more widely available as well. To kick us off today, we have a member of our steering committee, Monica Wayford, joining us. And I'll talk a little more about the steering committee a bit later in the presentation, but did want to let you know that the Link Center is governed by a steering committee made up entirely of people with lived experience, from across the country, from lots of different backgrounds, but individuals who identify as having a cognitive or developmental disability or communication difference and mental health support needs. And the steering committee has already made tremendous contributions to the Link Center and the direction that the Link Center will go over the course of the 5-year work of the center. So we're especially grateful for Monica and another colleague who helped really develop the work today for joining us today. And Monica Wayford brings a lot of wonderful experience, as you'll see in a moment. Monica served as the community advocate for victims of violent crime with the Central Council Tlingit and Haida Indian tribes in Alaska. She also served as coordinator for State Alaska Senior Vocational Services. She's been a certified peer specialist since 2007, and it's my tremendous honor to hand over the speaking to Monica. Monica, please.
Hi, I am going to describe myself. I am a 65-year-old brown-skinned lady who smiles a lot. Next slide. So at this meeting, we will be talking about crises and strategies people use to address crises. So we need you to take care of yourself because some of this can be triggering. Allow silence to be your safe space and feel empowered to do what's necessary for your comfort and care. Next slide. Want to introduce and talk about the 988 Suicide Crisis Lifeline that's nationwide. This is a great resource for turning to if you find people who have come to that point where they're thinking of suicide as an option. Next slide. So we're going to talk a lot about crisis planning and supports. Want you to think about where you work or people that you have dealt with in your practice, how those supports came about, how individualized are those supports. One size does not fit all. Next slide. So we celebrate individuality, our diverse cultures, and our singularity, while we celebrate the discoveries realized in our collective humanity. We know that we each have unique experiences in this world. Next slide. We empathize with experienced traumas that hinder our resilience. Some people have experienced trauma that makes it hard to recover and move forward. Next slide. We listen with open minds, compassion, and without judgment or blame, because what place do either of those have in our treatment of people who need us? Next slide. Lastly, we reject failure and we embrace hope. Next slide. So in the group, I'd like to just say a little bit about me for a second so you know kind of where I'm coming from. I'm a person with lived experience. I'm a certified peer, like Mary said, since 2007. I'm retired now. I personally have had 4 attempts at suicide. 2 of those attempts sent me to the psych ward, and 2 of those attempts were without clinical intervention. So to overcome the 2 that I handled myself were my motivation for coming up with my own treatment plan, which I've carried throughout, and it's called Prescription Positivity. This plan is an ongoing process of finding value in life. Finding what gives life worth is like discovering new currency for me. It's the value I place in being here for my family and having them near me. The value I place in the option to make my personal space and my environment what feels comfortable to me. Those things are what I hold dear. They're valued treasures that give me strength, reason, and purpose. When I felt that I couldn't go on with my life, I determined that the reason I couldn't go through with my plan to end it was because those things that I valued, those treasures in my life, meant more to me than the prospect of death. My prescription for finding positivity saved me from sinking into that hopelessness that comes with suicidal ideation. Finding the value of things that made my life worth living gave me the strength I needed to live my life. If I felt the familiar hopelessness that sent me into a crisis mode, I remembered those things that gave my life value. I became a peer support specialist when I learned I had the ability to empathize while others around me were only sympathizing. I realized by being a peer support that I could share the tools that worked for me. My insight gave me the ability to calculate the tools available for my clients' use, and then to contribute to my or my team's efforts of helping that person see the worth in their lives. I became focused early on in understanding resources within reach of my client. You know, those little things like insurances and funding. Customer service for me has always been a priority. And as I developed work ethics, it was important to me to know the benefits of everything a person has to offer, clinical, patient, what have you. And finding those treasures for that each individual can offer is finding value. As a practicing peer, for me, it has always been a delicate balance between professionalism and self-care. Sometimes my empathy will trigger my own crisis. My environment can be crushing because of my disability, or it can support me spiritually and physiologically. That's why shared learning to me is a nourishment for both my brain and my spirit. So that's about me. And in the group, I want you guys to know that we're going to talk about what the Link Center is. We're going to talk about supporting someone in crisis, what resources, training, and information are available to support someone before, during, and after a crisis. We're going to do a group exercise at the end, and we hope that people will participate. What challenges, solutions to supporting people in crisis, and this will focus on audience participation and ideas, shared learning. Thank you. Next slide.
Thank you so much, Monica, both for grounding us in the principles that we all hope will sort of enter the conversation with today, but most importantly, for sharing your own journey and the experiences that have led you to really help shape this conversation today and a lot of the work of the Link Center. So thank you again, Monica, for all of your work. As we begin the conversation today, we'd love for all of you to have in your mind's eye what your go-to resources are, what trainings, websites, and where do you go to get information about crisis planning. And just to be thinking about this, we will ask again at the end of the session, but as you'll see as I go through a brief description of the Link Center and our hopes for really elevating good practices, identifying strategies to better support individuals with cognitive or communication differences and to ensure strong mental health treatment, we want to ensure that we're trying to identify the best resources available and making those as widely available as possible, and most importantly, accessible as possible, so that people with lived experience and their families can really partner with direct support professionals and clinicians to work together in supporting individuals to have a good life in the community. So next slide, please. And what is the Link Center? And you can hop right to the next slide. Thank you. The Link Center was funded last year in 2022 by the Administration for Community Living, and we are eternally grateful for their leadership on this issue, recognizing that individuals with intellectual and developmental disabilities, brain injury, other cognitive disabilities, and folks who communicate atypically often have difficulty accessing strong mental health treatment. And there are lots of barriers and contributing factors to that we hope that the Link Center can help to overcome during our time together. We also recognize that the work of this center can't be done by one organization alone. It's really necessary to have strong partners in this work. So the National Association of State DD Directors, that's who I work for, NASDs, has partnered with NAD, formerly the National Association of Dual Diagnosis, and the National Association of State Mental Health Program Directors to lead the efforts of the Link Center. But we are in strong partnership with several other key partners, some of whom you'll meet in some detail today. But we're especially grateful to the leadership of Green Mountain Self-Advocates, the Autistic Self-Advocacy Network, the National Association of State Head Injury Administrators, Communication First, the National Center for START Services, the Sonoran Center of Excellence, and the Ohio State University's Nisonger Center. Each of our partners brings an important skill set to the work of the Link Center, and we're really trying to elevate those elements that are going to be most successful in coming together around supporting individuals with cognitive differences or communication differences in being successful in mental health treatment. Next slide, please. Our key goals of the center are threefold. Our hope is to identify opportunities to improve policies, service design, and service coordination to really create systems change. We know in many states and across the country, individuals with intellectual and developmental disabilities and cognitive disabilities have difficulty accessing mental health treatment for a lot of systemic reasons. And our hope is to identify those reasons and remove those barriers through systems change. But we also know the important pivotal role that direct support professionals and clinical professionals play in making sure that individuals have access to the services they need. So our hope is to offer a wide array of resources to help build a diverse workforce to support individuals with their mental health and their community living, to really bring all those elements together successfully. And then at its basis, we're really hoping to also identify strategies to improve service access. We know all too well that mental health services can sometimes be a challenge for anyone to access, and layering in communication differences can sometimes make that exponentially more difficult in our communities. So our hope is to really identify really strong practices to help really make a dent in all three of those areas. Next slide. You'll see in this slide a graphic just illustrating some of the key components of the Link Center. And know that on the left-hand side of the slide, all of our work is rooted in an effort toward keeping an eye toward the diversity, equity, and inclusion, making sure that individuals supported and the professionals that support them really have equal access to information and are able to really engage meaningfully in ways that are culturally and linguistically appropriate. So we've got a keen eye toward that. We're also dedicated to a continuous quality improvement approach. So as we enter the shared learning groups, this is our first foray into this group as a perfect example. We're very much hoping to hear from folks on how we can improve and make things better, to both share information, but also gather information and ideas from the strong community of folks that are represented here today. And we are, of course, as I mentioned at the top, really leaning into being governed by our steering committee, individuals with lived experiences. And while the steering committee has 12 members from across the country from very diverse backgrounds, we know we also have to reach out to other communities and understand from a broad array of voices all of the different considerations that the Link Center needs to take into account. And so we're also leaning in with expert contributors and through these shared learning groups to get the perspectives of a wide array of individuals across the spectrum of the individuals we hope to impact. We will have a website available soon. It's sort of coming soon. And through that vehicle and others like this, our hope is to elevate some resources that exist today. We've got tremendous research partners who've done a lot of work in this area, and we want to make sure that all of that's accessible and readily available to the community. But we also want to make sure that things are accessible in plain language and understandable by the widest array possible. So we're also identifying places where there may be gaps in resources, where the Link Center can make some contributions there. So just to give you an idea, we are just beginning our second year. And so we are excited at the prospects of the impact that the Link Center can have. But as you can see from this work, we are really interested in knowing sort of what your resources have been up to this point. What have you found most successful, or where are places that you've struggled to really obtain or gain information that you feel would be especially useful in your day-to-day activities? Next slide. So our hope today is sharing sort of what we're doing at the Link Center, especially related to supporting someone in crisis. And hopefully by the end of this conversation, you'll be able to identify the importance of crisis support and planning for people with IDD, other cognitive disabilities, brain injury and communication differences, and mental health for the Link Center. And that you'll know where to find resources related to supporting someone in crisis. We definitely want to get your input on this topic of supporting someone in crisis. And through that, we're hoping that you can identify necessary resources that might not be readily available or other resources that you'd recommend strongly to your colleagues. And then we'll also have a conversation, and Monica described this a bit, where we're going to have a group exercise, putting a challenge out there targeted to clinical professionals like yourselves, really hoping to gain some input on potential solutions in the hope that we can sort of collectively learn from one another and brainstorm about things that are most effective in interacting with individuals. Next slide. It's my great honor to turn the mantle over to my colleague, Dr. Stacy Nonamaker. Dr. Nonamaker is the Director of Cross Systems Strategies here at NASDS and has done a tremendous amount of leadership on pulling the shared learning group and other aspects of the Link Center together. So it's my honor to hand the speaking to Stacy. Stacy.
Thanks so much, Mary, and hello, welcome. Good afternoon or good morning, maybe for some of you. Thanks so much for joining us for our inaugural shared learning groups. I'm a middle-aged white woman with brown, straight, shoulder-length hair. I'm in front of a white background with my usual black top on, and I'm wearing glasses today. So we're going to really just kick off what we're talking about today with our shared learning group around supporting someone in crisis, and you know why we think it's really important to be talking about crisis planning and crisis support as it relates to people with cognitive limitations and mental health support needs. So we know, and we've identified crisis planning and support as a critical topic with the Link Center. And we know that people come to this conversation with different experiences, different histories with crisis, and different perspectives. So as clinical professionals who are here with us today, recognizing that although you all have perhaps similar roles, that there are really differences when we talk about your relationship to crisis. And I think that in the introduction, Monica did such an amazing job talking about both her personal and her professional relationship with crisis. And so just to maybe dive a little deeper into these differences and how crisis really can be very individualized in how we define it and what it looks like for us. I'm going to ask you to engage with us a little bit in the chat. And first of all, I do want to say thank you so much. I see you already putting some really good resources, trainings, and information in the chat. Keep it coming. But really to focus on this concept of crisis, we're asking you in the chat, what is the one word, and maybe we'll give you 2 words that would really describe for you in your role as a clinical professional, what crisis looks like as you support someone. So take a moment, just think about that. Pop it in the chat. What's the first thing that bubbles up for you? Oh, be calm. And not make the situation worse. Yeah. Noticing a theme here already. Okay, keeping calm, compassion, concerning, peril, understand the situation, validate feelings, have patience, listen, empathy. A lot of listening, a lot of being calm, compassion. Every crisis is unique. Agreed. Validate feelings and follow through. Be thinking of supports and resources that can be connected to. Person-centered, joining. These are so great. Trauma-informed listening for the need. And I'm already thinking about We held a shared learning group earlier today with direct support professionals, and what an interesting comparison to the things that they said when we asked this question of them. And really, as these are coming in, the point here again is, while crisis can, in its simplest definition, be defined as a time when things are not okay, what crisis looks like, how it's experienced, what your role is in it, is truly, as you're pointing out here, individualized, and it's based on a great number of things. Again, including the role that you play. I'm making some comparisons here, and really excited to dive in tomorrow with individuals with lived experience and families, and see how they define and describe what crisis looks like. So thank you so much, and just a great way to really be kicking off, and again pointing out that the way that we define crisis is informed by what we bring to the table. So now we're going to pivot and talk about the research and the science that's out there. And I'm going to turn it over to Dr. Deborah Peinels, who is a forensic psychiatrist and a consultant to this grant. Dr. Peinels is also a senior medical and forensic advisor with the National Association for State Mental Health Program Directors, and has extensive, amazing experience supporting people, and also supporting people and public systems. So Dr. Peinels, I'll turn it over to you. Thanks for joining us.
Great, thank you. Yes, it is a pleasure to be here. I am, for those of you that may be visually impaired, I am a white woman with dark brown hair, short, and wearing a sweater and a necklace today, a black sweater and a pearl-shaped necklace. And I wear glasses to help me see what I'm supposed to be saying. So we can go to the next slide. Let me just kind of frame some of the things from my clinical perspective as a psychiatrist who spends time in emergency services and is working on crisis services in a lot of different venues. You know, really what we want to start with is defining what is the issue and the need that we're trying to build upon and solve for. So first of all, we know, and we can see already from the chat, that we need options for people with IDD and mental health support needs who can get support at every stage of a crisis. And a crisis can come in many forms. We want to be able to prevent crisis. We want to be able to address crisis, and we want to be able to help people in the post-crisis stabilization and intervention period. We also need trained people supporting someone in crisis. And that's one of the points of this shared learning group, to hear from you what you know, so that we can continue to learn as we build out the resources in the Link Center. So we know that there are negative outcomes happening right now that we want to reduce. For example, all too often, people with IDD and mental illness are in crisis, are encountering police, where they are at risk of all sorts of negative outcomes. The most, including arrest and incarceration, and even overuse of lethal force. We know that we have people in emergency departments waiting for placement, and that people with IDD and mental health and complex needs are disproportionately stuck in emergency departments unnecessarily. Now, emergency departments are important places in our continuum of care. And so we want to get the right people in those places at the right time for the right reason. Similarly, psychiatric hospitalization is important when people need it, but we want to avoid hospitalizations that are not necessary. And so we really need to improve our crisis continuum so that we get those proper responses. And counterbalancing the negative impacts of fewer appropriate crisis resources are that we need more connection to proper supports in the community. And that's, again, one of the things we're trying to build out through these conversations and building out resources to help people make those connections to, again, both avoid crisis and manage crises in all the forms that they come in. Now, we know that 988, the national 3-digit number for mental health and substance use crisis, is rolling out. We're doing a lot of work on that. In this grant, we're working with SAMHSA, the Substance Abuse and Mental Health Services Administration, and the Administration for Community Living to try and help figure out how to best address the needs of people who call 988, who also have IDD and mental health. With 988 is coming a lot of mobile crisis responses to try and reduce the contact with police when that's not necessary or appropriate. And so there is a lot of work to do, and we are sort of building the bridge as we walk on it. So we need to be informed by the science that exists, although I saw in the chat people asking questions and wanting more research in certain areas, and I'll talk a little bit about that. So we can go to the next slide now. So what does the research tell us? Well, as I said, there is not a lot of research on how to best serve people with IDD and mental health needs in a crisis setting. And certainly because our crisis system is in a sea change, we're going to need more research as new services unfold. But there are some published studies that support some evidence in the literature that I think is important to anchor ourselves in. For example, a series of studies showed that there is a need to come together and support and educate people who work at hospitals. Again, this was hospital-based crisis services because that's what has existed historically, to better understand and get more comfortable talking to and caring for people with IDD. Certainly as a psychiatric emergency room physician in my career, I have seen over and over again that we need more information and more education of staff working in these settings to best support people who come in crisis with these backgrounds. We also know from a paper that I wrote with my colleague, Dr. Edwards, in a review of the literature, that people who help people in crisis need to learn the best ways to offer person-centered support. And not everybody is familiar with the concept of person-centered support. And so that's something we also have to provide a lot of education about and refreshers and reminders. Every person is different, and crisis care can reflect that. We'll hear later about unique aspects of one individual's crisis support plan. Next slide. Additionally, from another study, we see from the research that some things can make people more likely to end up in the hospital for a mental health crisis. For example, how their disability affects them. If it does lead to those difficulties and emotional crises, or if they're having challenges getting their needs met. Whether somebody lives in the community or in a group home setting may impact whether they're more or less likely to go into a hospital for a mental health crisis. A history of mental health hospitalization or going to a hospital for a mental health crisis will predict more likelihood of returns. And so we want to think about people who are in that cycle of going back and forth to the hospital. And also whether police have been involved can be another driver of what makes people more likely to end up in the hospital for a mental health crisis. And frankly, also what makes them more likely to be rearrested for a mental health crisis or have a police contact. Other things can make it easier to stay out of the hospital during a mental health crisis, like having a family doctor who supports a very well-integrated plan, and or having a crisis plan so that the individual can pre-plan how to best respond and how to look at what a crisis looks like for them as an individual. Next slide. Now, there are crisis models that are out there and that are emerging even more. For example, the START model, the emergence of more and more certified community behavioral health clinics, which are have standards for how to operate. And one of the standards are that they must include crisis services and they must serve anyone who comes to their door for an assessment, and other models that are emerging. And we know from the emerging models that there are pieces that we can take from them that help them establish more success in responding to crisis. One is having system connections. People come in crisis with all sorts of needs. It could be that they have housing needs or food sustenance needs, or they could have IDD needs and mental health needs, and we need those systems to be connected. We're certainly seeing a lot of that with youth and schools, for example. The inclusion of physical health. There's lots of discussion, and we're working at the National Association of State Mental Health Program Directors to think about what are the medical services that are needed to help people in behavioral health crises. They also will need, the success will be determined by having many available services, because again, different people will have different needs, and we need to make services available to meet the unique needs of anyone who comes in for a crisis response. We also need trauma-informed response. We can say that the number of people who are struggling with mental health and IDD issues, who have histories of trauma, either in early developmental years or even as adults, are enormous. If not everyone has some degree. But because it is so common, we need to make sure that the supports that are offered really have a sensitivity and are informed by the literature on how to address trauma in those moments and how to be trauma informed, and how to refer people to trauma-specific therapies that are appropriate to their unique needs. And then also we need to look at evaluations. Successful evaluations will help drive the next step in care planning for people. So does the evaluation work? Is the evaluation geared for somebody with these complex needs in this population? And if not, what changes do we need to make to ensure that our evaluations drive the conversation forward in a way that's going to be most impactful in a positive way for the individual who's coming in for crisis services or being seen for crisis services in their home environment? Next slide. So what does all this literature mean for clinicians? Really, as a clinician, try to think of some things that it might mean. But as I'm talking, would really love to see in the chat, what have I missed? What have we missed? What more can you think of? What can you tell us that you need, and what the literature tells you? What does it mean for you? So some of the things we thought about are that clinicians do need to gain additional knowledge and training about IDD and mental illness, and what they look like in co-occurring when they co-occur, and what they look like even separately. Will help getting that additional knowledge will help clinicians do better supporting people. We also need to realize that clinicians may need guidance on person-centered practices. As I said, many clinicians in the general mental health field or working in settings where crises might be responded to might not understand person-centered practices. Also, clinicians can ask people whether they have a crisis plan, since we know that having a crisis plan can help that person drive their own care in a person-centered way when they are in crisis. And clinicians should ask people about their living arrangement to better understand stressors and experiences, because remember that one piece of data that showed that people living in group home environments or in communities may have other different stresses, and that can help inform the clinician who's trying to figure out how best to support that individual. Next slide. And I see some people putting in the chat, and we'd love to hear more from people to put in the chat, what does the literature show you as a clinician serving people with IDD and mental health in crisis? And what more do you feel like you need to best serve people? All right. And as you're thinking about that, I want to turn this over to my colleague, Ren Coloni, who worked with us very carefully and did a fantastic job helping to develop a crisis plan and show us what their experience is. So let me describe Ren. Hi, Ren. Ren Coloni is a program associate with Communication First, one of the Link Center's partners. They developed a guide for people with IDD to learn more about crisis plans using knowledge they've gained from their own lived experience. And I'm really excited now to turn this over to Ren.
Hello, everyone. My name is Ren Coloni, and I use they them pronouns. I'm a fat, white, non-binary person with rectangular glasses and soft dark hair, half of it shaved, half of it in a long braid. I'm rocking gently back and forth. I came into this conversation as a program associate with Communication First, a partner of the Link Center. We are the nation's only nonprofit organization, working for the civil rights of everyone in the United States, who cannot rely on speech alone to be heard and understood. Not all people with IDD have speech disabilities, and not all people with speech disabilities have IDD. But across these communities, we have many things in common. The ways we live, think, move, and communicate are so often met with confusion, discomfort, fear, or abuse. And our basic needs, as well as our basic human rights, are not always met and respected. As a result, we tend to carry a high burden of trauma and suffering. Right now, our communities and our health care systems are not prepared to help us weather that suffering or heal from it. The Link Center is doing work that, I believe, will start to change that. As an autistic person with complex post-traumatic stress disorder, dissociative conditions, and a handful of other psych disabilities, I know firsthand the importance of this work. In many ways, I've been lucky. I have never been hospitalized or institutionalized for my psych disabilities. Though I am a part-time AAC user, I have never had my voice taken away from me because it was deemed a safety risk, but I do know people who have had that happen to them. And I have a strong support system, able and willing to help me, when I can no longer help myself. Many of us, especially those of us who are unhoused, don't have that support system. So, I count myself lucky. But I've also lost months of time to dissociative episodes, months where I could not care for myself or take part in the world. I've had breakdowns in bathrooms and bus stops, in bedrooms and ballrooms. I've hidden common household objects from myself, so I wouldn't end up in the hospital. And, I did all of this more or less on my own. Seeking care has never been a real option. Maybe I didn't have the money for the copay. Or a psychiatrist told me he didn't know what to say, and that I didn't need to come back. Or a therapist looked uncomfortable, and changed the subject. All my care has, ultimately, come from me, and from a small circle of loved ones. I have survived, but going through it so alone, has been dangerous, painful, isolating, and exhausting. Despite all of this, I still have enormous faith in the power of mental health care. I spent most of my time in college learning how well it works, when we do it right. And I've met so many professionals who really, truly get it. It's impossible for me not to believe in that potential. But I also believe in the tremendous power and importance of sharing lived experience. When people with IDD, who have been through crisis and suffering, come together to pool our knowledge, we can create incredible change for each other, and for the peers we haven't met, too. A few months ago, folks from NASD's asked Communication First for our thoughts on supporting people with IDD to navigate crisis. I found I had a lot to say. For example, I pointed out that when we're in crisis, the way we communicate often changes. I usually have access to speech, even if I prefer typing. But in an acute and overwhelming crisis, I have no choice but to type, and even then, my words may be slow, or difficult to understand for people who don't know me. Other people I know, no matter how they communicate when they're feeling well, rely on pictures, gestures, or a person who knows them very well, who can help translate. The people supporting us during crisis need to know how to interact with us, no matter how we're communicating. That means that they also need to know how to respond when I do things they aren't expecting. For example, my rocking, flapping, and slapping helps me stay present in my body. We should never be viewed with fear or disgust for regulating during stress. And we definitely shouldn't be restrained, isolated, or assaulted. But for many of us, ableist mistreatment of all kinds is a looming threat, never too far from our minds. We can't afford to forget about it. Here's an example. I wouldn't feel totally safe calling 988, just because of the chance they could call the police, a situation that would involve dire risks to my health, safety, and life, as a multiply disabled person. 988 is doing a lot of fantastic work to make the chance of police involvement as small as possible. Early data suggests that the chance is less than 2%. That is amazing. But I would still feel infinitely safer calling one of the few lifelines that refuses to contact police under any circumstances, like the Trans Lifeline. Even though it might be a lot less accessible, due to a lack of funding. Or, more likely, I might just decide not to reach out to a lifeline at all. In a mental health care system that can be inaccessible, and even hostile, to people with IDD, I feel strongly that one of the best things we can do is put as many tools as possible directly in our hands. For example, having a crisis plan doesn't prevent or fix crisis all by itself, but it can make it so much easier, safer, and smoother. Working with my lived experience, as an autistic person who has been through, and helped others through, crisis, as well as my academic experience with mental health and disability, I took a look at existing crisis plans, and adapted them into a toolkit, focusing on crisis plans. The toolkit starts by explaining basic ideas about crisis in plain language. It offers tips on what people with IDD may want to include in their crisis plans, based on my experiences. It introduces 988, and defines words that we often hear surrounding mental health crisis. And I included 3 crisis plans that I think work well, along with a short version of one I drafted on my own. When I'm in crisis, I need to know exactly what to do. I don't have the energy or brainpower to try to come up with a plan on the spot. For me, a good crisis plan tells me what steps I need to take, and when to take them. It tells people about the kind of care I do, and don't want, and lays a foundation for some of the decisions I would make, if I were in the right headspace to make them. It also puts everything that other people need to know about me and my disabilities in one place. I also feel strongly that crisis plans should be adaptable for many different kinds of crisis. To me, crisis is stress that is unmanageable, overwhelming, and all-consuming, and that also puts me, or others, in danger of some kind of harm. But the results of that stress are different, depending on many factors. My crisis isn't always about wanting to die. Sometimes, like with my dissociation, it's about not noticing I'm alive in the first place, and being unable to care for myself as a result. Or, it might be a meltdown, a shutdown, autistic burnout, or a response to a trigger. None of these crisis situations is necessarily worse than the other, but a crisis plan can help me, and the people around me, to prepare for each one. This crisis plan isn't based on research, and it shouldn't be taken as medical or legal advice. Instead, it's based on my own experiences with crisis and my understanding of myself and my community. But, of course, there is no single crisis plan for every person and every situation. Different people need, and want, different things as they navigate their mental health. So, I won't try to offer a one-size-fits-all solution. Instead, I hope this toolkit will guide and inspire people to think about what matters to them and their lives. I hope that people with IDD can feel empowered to talk to people who support them about their mental health and make a plan for the future together. And I hope that people who may not have a strong support network right now will start to feel that they are not alone. Each day, organizations like 988 and local community crisis teams are learning how to support us in ways that honor and respect who we are. And others in the disability community are here for you, too. I think that people with IDD know ourselves best, and that we gather wisdom each time we experience a crisis or go through intense suffering. When we have access to the right tools, we can make the most out of the knowledge we have gained over a lifetime of living in our bodies and minds. And we can begin to make sense of that knowledge to the people who want to help us. This guide certainly doesn't have all the tools we need to heal, but I hope it's a good start. I'd like to thank the Link Center for including Communication First as a partner. If you'd like to learn more about our organization and our work, visit our website at communicationfirst.org. And I'd also like to thank the Link Center's steering committee for the knowledge they're sharing. This is vital work, and I'm grateful to be a part of it. One last thing. To everyone listening who has experienced crisis, I want to thank you, too. I say that the Link Center's work of supporting us is vital, and it is. But the most vital work of all is doing what you can to live and love this beautiful world of ours. Thank you. I'm glad we're here.
While we're on the thank yous, thank you so much, Ren. I have said this before and I'll say it again. I have learned so much from you and Monica and others who are sharing their story, particularly around such a potentially very difficult topic. So I once again just want to thank you for being here and for showing up. I hope that the rest of you have really pulled some practical recommendations to consider as we support someone, as we plan for crises. And the two resources that Ren mentions, we'll pop those into the chat for you all. So really it's two resources that make up a toolkit, and I'm just going to show you two screenshots. The first resource, Making a Plan for When I Don't Feel Okay, is really a robust crisis plan that Ren has put together as a result of their research and looking at what's out there. And I think it's such a beautiful contribution to what's already out there. And it's something that definitely I think you all should take a look at. And then the second resource that makes up this toolkit that Ren was talking about is What to Do When I Don't Feel Okay. And these are really some big ideas or considerations for people who use and could potentially benefit from a crisis plan, as well as those of us who support them. So really this guide looks at, starting from the beginning, what is a crisis? why do I need a crisis plan, and who can help me, and what should people know about me, and how to support me. So again, we drop those into the chat. And this is the place that Mary mentioned earlier, and I know Deb and others have said, this is shared learning groups, and certainly we're looking for you all for feedback on the things that Ren has developed, taking a look at the things that Ren has developed and what's out there, and really letting us know as the Link Center, what are some things that you're identifying that aren't out there that would be so helpful to your role as a clinical practitioner, clinician who's supporting somebody, helping them plan for potential crisis, helping them through a crisis. So that really would be a way that you all could be engaging with us at the Link Center, so that we can be elevating things that are out there, like these sample crisis support plans and templates that are out there that Ren mentioned, that are also contained within the resources that we put in the chat. But then, where are some gaps that you're seeing? So we can elevate some things, and we can see if there are some ways for us to really take some of that feedback that you all have for action. So speaking of action, this is where we're going to bring you all into the conversation and pivot to a group exercise for the last half hour or so that we're together. So what we're looking at is, this is called a capsule exercise, and simply put, it's a structured conversation that we're going to facilitate with you. And thank you, Monica, for coming up, and Monica is going to help me introduce this exercise as well. It really is going to center around what we consider to be a relevant, relatable challenge issue that I'm sure, and I'm also hearing through some of the chat and some of the Q&A that you've already been thinking about this particular situation that we'll share with you in just a moment. So we'll present this challenge, we'll present this issue with a focus on having a few volunteers, 3 at the least, maybe 5 at the most, who would be what we're calling reactors. So these are people who will take this issue on as if it's their own and start brainstorming amongst one another about what are some ideas, what can we do here? Brainstorming solutions, right? Because where there's a challenge, where there's an issue, where there's a barrier, we should also be seeking solutions. And hopefully those of you who are willing to come up and do this exercise with us will be, modeling that really problem-solving approach, bringing ideas, getting really the wheels turning around how could we really address this problem. I'll also say that the rest of you will be witnessing this. For those of you who don't volunteer, I'm sure you're going to have some ideas or some go-to strategies and solutions if this is something that you can relate to. And we're asking you, put that into the chat. We want to have some conversation and some engagement with you all that are in the chat. So those of you who are volunteering, pay attention to the chat as well. And no pressure. Earlier today, the direct support professionals really stepped up and we had an amazing conversation around their issue and challenge. So before we ask you to either raise your hand or ask to come off mute, I'm going to ask Monica to read the challenger issue that we developed for you all, and that may spur some interest in those of you who would be willing to step up and be a volunteer. So Monica, let me pull up. There we go. Turn it over to you, Monica.
Thank you. For all of you burned out clinicians, this volunteering will add to your PTO time. Just kidding. I wish. This is the exercise, and feel free to ask questions. So as a mental health practitioner, I have very little experience supporting someone with an intellectual disability. Recently, a person from Rose's group home brought her to my office because she has recently been diagnosed with depression and anxiety by her PCP. The staff person seemed it was important to be in the room, and while I would normally engage someone who struggled with depression and anxiety in cognitive behavioral therapy or CBT, Rose doesn't like to talk to people they don't know, and I am not sure CBT would make sense for them. What should I do?
Great, thank you, Monica. All right, so again, as a reminder, if we could get 3 to 5 people who would volunteer, you don't have to come off camera, you can stay off video and just open up your mic, but please go ahead and raise your hand or ask to come off mute, and we'll bring you up as a reactor. Okay, thank you, Erica. Wendy?
Can you hear me?
I can hear you, Erica. Thank you.
Okay,
we're
yeah,
going to
I
bring-
was just going to suggest that the clinician might want to talk to the staff who's with Rose. Usually the direct care staff know people pretty well, just to see like what her coping skills have been, how she usually communicates with folks, if she's involved with any kind of counselor, what coping skills the team has supported her with in the past. Just I would be asking a lot of questions at this point to find out what resources this person has.
Great. Thanks for jumping right in, Erica.
Mhm.
And I'm going to go off mute. I know Erica and Wendy were reactors. I think I saw a third person raise their hand. Stephanie, did I miss somebody? Hoping to get a third person in here.
There was,
Sorry,
but I
Erica.
think they put their hand back down.
Okay. So maybe one more person interested in brainstorming up here with Erica and Wendy. Thank you, Debbie. All right, great. So again, I'm going to go on mute so that Erica, Debbie, and Wendy, you can have a conversation. And I don't want to lose what Erica said around talking with staff and getting more information, particularly around coping skills, communication, etc. So I promise to go off mute now. And Shonda also, thank you.
I was going to say, let's talk to the person, right? Let's talk to Rose and explain it to her and get some feedback, and maybe not assume because she doesn't like to talk to people, she doesn't know that she wouldn't be interested or willing to engage with you in that way.
Yeah, absolutely. And I think also like asking Rose, how she sees, what are her ideas, so that she can participate in the discussion and the treatment and a plan, like, moving forward. I think it would be really difficult to go into a conversation with somebody you don't know. You've been diagnosed with depression, anxiety, and trying to muddle through those feelings with somebody you don't know. Like maybe she has a safe person she could identify, and that person could be part of those meetings or discussions or sessions or whatever too.
Maybe taking some time to get to know each other before you jump into therapy, right?
Sure,
Little self-disclosure and allowing, some bits about who am I as a person and to build a relationship too.
Right.
Yeah.
And I'm not a clinician who would be, administering CBT, but this clinician says, I don't know if it's right for her. Well, what other resources or what other therapies could be tried? There's a million different therapies that maybe could be utilized and be more suitable for Rose.
Yeah. Yeah, I see somebody else put in the comments,
Mhm.
take time to create a trusting relationship and then ask. So looks
Sure.
like there's some consensus. I know there's other people that were part of this conversation. I don't know if we're,
Yeah, I would, I agree, talking to the staff, they know a lot about everything. I also agree about talking to Rose. I don't think it's a either or. I think it's
agreed.
a
Absolutely.
conversation. You're both in there, and asking, what changes have happened lately? Like if we have recently started engaging with struggling with depression and anxiety, what changes have happened recently that might have triggered this? Is it something socially that has happened? Did her best friend move out of the group home and we just assumed that, that didn't affect her? Or, maybe she's not feeling well physically, which is now manifesting itself this way. I know sometimes when I get physically ill, it makes me feel more anxious. So I think there's physical things that could also be, or medical things that could also be triggering this as well. So definitely that conversation with the both of them. This isn't a once and done thing. This is an ongoing thing. And yeah, there's lots of therapies out there, not just CBT, but don't just assume that she wouldn't be able to make sense of CBT because she has an intellectual disability.
The other
Yeah.
thing you notice is the staff person seemed it was important to be in the room, but does Rose agree that it's important for that staff person to be in the room? Does she want that staff person to be in the room just because they have a relationship? Is it a safe relationship from Rose's perspective? So find a way to get to that also, I think would be important.
Right. Maybe Rose wants a different staff member with her, not this particular staff, because just like we have favorite people, I know the people I've worked with in the past have favorite people too. And unfortunately, I'm not the favorite all the time.
Absolutely.
And she might just want that intimacy where she doesn't want anybody there. So that's good that you pointed that out, because a lot of times when we support individuals with intellectual disabilities, we always assume we need to be there 24/7, not really allowing the person that intimacy and that one-on-one, because I mean, that's like with any of us, we are going to have a conversation and you might have a family member sitting there, providing their 2 cents, or just being there makes things awkward. And I also agree about the whole medical thing, following up to address that first, because like someone had mentioned, if she's going through something medically, like you mentioned, it can manifest where now we're more anxious, now we're more depressed. So definitely rule out the medical. And then, and I know I'm kind of tying in towards the end, but also just letting her know who I am and giving her a reassurance that this is a safe space, and just kind of just seeing what her needs and priorities are. And then like before, asking if she felt comfortable with the staff present, but then also checking up with the staff afterwards, just giving them, just the clinical insight, but also letting the individual know that whatever's disclosed is going to be between us.
Absolutely. Trying to help build a safe spot for her.
Just wanted to point out to our reactors that there's a lot of chatter happening in the chat. If you want to take a second and look at some of the ideas and solutions that people are offering there that you may want to react to as well.
Mhm.
Yeah, I did look at a lot of it as it was coming in, and I think there's a lot of themes. I think most have been discussed, but not all.
I see Alt Play, the link for Alt Play. I'm looking at it right now. Never heard of this.
think that one of the comments said it was great for kids. And then there was another comment about be sure to use nonverbal communications as well as verbal. So I guess, don't rely just on talk therapy. Yeah, I'm not familiar with it either, but.
I'm on their website. So it says it's a framework for implementing play therapy. Address mental health needs, neurodivergent children. Looks like it's mostly for individuals 3 to 18.
Yeah, it says the chat says specifically for neurodivergent kids. Great. And does this say how old Rose is? I guess she's in a group home, so I guess that gives us some idea.
The other thing that I think we all alluded to, but we didn't actually say, is that we always need to keep in mind that that individual, the individualized thinking, what Rose wants as well as what she needs. We need to come up with a plan or help Rose figure out what she wants to do and how she wants to proceed in everything that we do. So everything is highly individualized. So there's great generalized things, but in the end, we definitely need to come up with something that's individual to Rose to help Rose get past her depression and anxiety.
And I think somebody else said they were not a clinician who would do CBT, and I'm also not trained to do CBT, but is it a practice that could be modified for Rose in some way to work better for her? I think most evidence-based practices can be modified at least some, right, to accommodate a person's needs. Somebody said yes.
Yeah, Brandy says yes.
For adults to take to the therapist to help them communicate.
That could be an interesting.
Yeah.
I had mentioned.
Yes, if you can share
And-
the link, that'd be awesome.
And who above that said more time for the appointment. That I think is definitely true. Because of a possible communication delay, it's going to take longer to get to the root. So allowing more time for those appointments. Good, Mary.
That's a good idea. I never would have thought of that.
It's interesting though, as we talk, because you wonder how much time we as clinicians really sit and think about that, because we're all so pressed for time, and it feels like I think that's one of our biggest issues, especially with the workforce shortage right now, is we don't take the time to really individualize our approach and think through all of these things. It's like things don't come in this nice succinct paragraph, and I don't know that we always give ourselves, it's not a luxury, but the time to really think this through. And so that might just be something to think about when we think about resources for the Link Center, is how do we I don't know, are there tools to kind of think through that process? A short questionnaire you can go through to kind of challenge yourself on, are there accommodations I can make? Are there people that should or should not be present in the room? Have I explored the person's, preferences for communicate or needs for communications, preferences for treatment? Does something like that exist? I see there's several people in the chat. I don't know if anybody addressed that, but.
I think there are many different tools out there that have all of that available. I don't know if it's all in one package or if it's kind of a build your own as you're going, piece and parcel from this and that to make what you need specifically for you and your clients in therapy.
Mary said the resource, Andrea, that you shared has many such considerations, so. Practice guidelines. Mhm.
I look forward to diving into some of these more when we're done here.
Yeah.
Yeah. And
Stacy, I'm
sometimes
not
just a
sure.
walk-
Oh, go ahead.
Yeah, I see Amanda said non-traditional activities. And yeah, sometimes if you just go for a walk, like walking and talking, the walking facilitates the talking.
I don't know if any of you have had a client participate in music therapy, but I got to witness that earlier. Well, it was last year actually. And the client maybe didn't fit this specific scenario, but in a 30-minute session, I saw her open up so much. I mean, my jaw dropped, I think, and I got teary-eyed watching her. But I feel like you mentioned non-traditional activities. I feel like there's a lot of that out there that could really be beneficial. Some people just don't have anything meaningful going on in their life. So, to help facilitate what is meaningful to them, can certainly help in this situation.
Yeah, music therapy is powerful and it can reach
Yeah.
people that in a way nothing else can. I saw that very early in my career and a huge proponent, huge
Mhm.
believer in it. Yeah.
So when it comes to music therapy, do you just refer the individual to a music therapist, or is that a skill you can like kind of add on to your credential by just doing research and finding literature?
The
I
one
mean-
that we worked with was an actual certified music therapist.
Okay.
And I've seen it used in a lot less structured way too, just music being able to bring people together or bring people, kind of to engage in a way they wouldn't otherwise. But yeah, to call it music therapy, you really have to have a therapist, but there's ways you can, I think, incorporate music into a lot of different group sessions, especially, but
I wanted to piggyback on what Ren had put in the chat. I've worked with 3 people who use the communication device. And the first person I worked with, I was actually direct care. And I do remember going with her to appointments as her direct care staff. And I would have to advocate for people because they would look to me to answer as she's trying to answer.
Oh, wow.
And I would have to say, she's working on it. You just need to give her a minute. So yeah, the importance of if someone's using a communication device, sitting and waiting patiently for them to gather their thoughts and put it out. It's not easy to get that information on that board, to get it to talk. So as therapists, we need to be quiet a little bit longer than we're used to probably.
And just to kind of tie into that, I noticed that a lot where if someone has a direct support staff present, instead of addressing the individual directly, they'll just go to the staff member, disregard getting the feedback from the individuals. Just even if they're verbal or nonverbal, I still recommend just talking to the person first and then talking to the staff as opposed to just talking directly to the staff.
Exactly.
So I'm going, amazing conversation and ideas and resources being thrown out there that I know we're all going to be adding to our toolkit. But one more minute, any last thoughts? Anything you want to rise up from the chat?
only to say there was so much good stuff in the chat. I'm sure we're capturing it all, right?
We are,
Okay.
and yeah, thanks for asking, Wendy, and thank you to the rest of the reactors. Thank you so much for being brave enough to come up and volunteer. And for those of you who were engaging in the chat, I think we heard a lot of really amazing ideas and resources, things that we can be thinking about. I think we heard some strong themes here around the importance of building rapport, the importance of including the person, being very individualized in our approach, focusing on modifying mental health practices for people with IDD. And there's a lot of resources in the chat for that as well. You know, and good ideas that were put out there around different communication modalities, more time for appointments, have the therapy happen somewhere else. And I love the conversation around other meaningful activities and therapies and how that can be woven in as a complement to the therapy at hand. So thank you so much for everyone. And that just beautifully captured, you know, the need for multiple perspectives when we're facing things that may be challenging us as clinical practitioners and clinicians. And this really intent was to show how if we open the lens, we don't know the backgrounds of all the reactors or people in the chat, but it really does help us get out of our own way, frankly, and put our assumptions and biases to the side so that we can really look at all the solutions that are out there, that we can think outside of the box, if you will, to support someone. So thanks everyone for joining in around that. Hopefully you got a couple extra resources and ideas for yourself for you know, going back to do the work that you do. So we're going to wrap up our time together today. And I know that you all have been amazing with doing this throughout our time together, but here's another prompt and an opportunity for you to get your go-to resources, trainings, website, any information or places you go when you're thinking about supporting someone, whether it's crisis planning or crisis support, that full continuum that Deb talked about earlier. You know, the crisis research that we've mentioned here and others, we're tagging them for all audiences and to have that up on our website, which will be coming soon, we promise. We're going to take today all of this really great feedback and sit with it and elevate what exists that we haven't already identified and take other pieces for action. Again, as we said in the introduction, and we'll say it again at the outset, we're really interested in taking the feedback from the people who participate in these shared learning groups and diving into them as the Link Center and really identifying and vetting things and taking into account the things that you've identified in your role, that there may be gaps or needs for you to do your work. So until that website is available, you can reach us by emailing us at the Link Center at nasds.org. And we have quarterly shared learning groups now, you know, starting with this one. So we're really excited to have so many people up here and so much engagement, both in the chat and in the exercise today. And I've learned so much just in creating this content for you all, but also from this conversation today. In January, we're going to be talking about the importance of supports for trauma. Then in April, we'll take a look at supporting someone through a transition. And when we say transition, we mean across settings, across the lifespan. So we'll dive into that. And then in August, we'll meet again to talk about supporting the whole person. So think about integrated care, think about multiple perspectives like we just practiced in the exercise, think about teaming. So we would love to have you join us with these additional shared learning group opportunities. And then, because you'll be getting the PowerPoint, here are the resources that Dr. Peinels used in talking about the research around crisis planning and supports. And again, cannot state it enough. We are so very, very grateful to the contributions of Monica and Ren in developing the content for today and being here during these meetings. Emily Brown is also part of the steering committee, and although they weren't able to be with us today, they have been very critical in the development of this content and the focus of crisis support and planning, and certainly all of the partners at the Link Center. Mary went through them, and there are many people to be thanking for the contributing to all of this content and preparing to talk with you all. So just a last piece of housekeeping before I let you go. And just to remind you, as Stephanie mentioned, we will be sending an email with all of the resources, including the PowerPoint, including what we put in the chat. We'll send you the recording and the transcript and also an evaluation. We've really acknowledge that this is our first foray into shared learning groups, and we acknowledge that they could be evolving because we really want to make sure that these are meeting your needs and that we are really in tune with what the different audiences need, from DSPs to clinical practitioners and clinicians to individuals with lived experience and families. So long and short of it is, please take a moment. You've already given so much of your time to be here with us today and be engaged and participate, but we're asking you for a little bit more of your time. When that email comes through, take a second and go through that evaluation. We'll take a really good look at that. And so thank you so much to everyone for all that you do and for finding the time away from the important work that you do and being with us today. It's been an incredible and informative time. So have a great rest of your day, and thanks again.